Great, thanks so much. Okay, so I know it's been a very long day. It's the very last talk, so I'm going to try to give some high emotion when I give this presentation. A lot of this is going to focus on nothing that has anything to do with Nextflow, and I hope that that's okay. But the goal here is to really talk about kind of just from the personal perspective, what it's like to be the user of everybody's great work in biomedical science, and that extends to the work that you do here. And then to also hopefully inspire everybody in this room to think really, really big and really focused all at the same time. Some of the things I'm going to talk about are huge barriers that I have faced personally and professionally, where if I did the thing that I was supposed to do, if I took one foot in front of the next and walked forward, I probably wouldn't be alive and I wouldn't be standing here today. And so that's kind of the goal, is to just kind of think big, but also very focused. So this was me back in 2010 when I was diagnosed with one of the most rare cancers there is. It's an exceedingly rare cancer called Angiosarcoma. It's a cancer that starts in the endothelial cells, which are the lining of your blood vessels. It only hits about 300 people a year. I was already a scientist at the time, about to defend my PhD in biomedical sciences at UMass Med, so I knew enough to really look deeply into the literature and find basically nothing. And as a data scientist, when you're faced with your catastrophic reality, it's just unconscionable to try to go forward with not any data at all. And so this was my husband, who was kind enough to shave his head so that I wouldn't be the only bald one in the house. But you can't really tell which one of us is sick in this picture. This is a really good representation of what it's like to kind of go through those early days. So the first time I went to PubMed, I typed in angiosarcoma, and one of the returns was long-term survivor lives 1 full year with angiosarcoma. And I was just completely devastated. It was awful. And I came to realize that I'm not going to find anything scientific here. I'm not going to find anything that's actually going to guide my therapeutic decisions. All I'm going to find is a world of hurt and not much attention whatsoever. So I went to Google. And at this point, I've kind of given up on trying to find anything that's going to be helpful at all scientifically. And I had to find somebody else to go through this with. It was so isolating to be just an N of one, right? Not one person could really understand. So I found, I put the request out there. I was like, are you looking? And I'm here. And I found people, I found hits. And I went to try to engage with them, and they wouldn't reply. And it turns out if I put their name in and then put obituary, they'd pop up every single time. They were looking too, but they didn't find anybody in time. So this was when Facebook got really big. And so I as a last-ditch effort, I put angiosarcoma cancer into Facebook, and lo and behold, there was a group. And there were 9 people in that group surviving this disease. And they were stay-at-home mothers. She's still alive, and she's a Disney Imagineer. And man, what a cool job that is. One was a cop. Yeah, I was the only scientist. I think I'm still probably the only scientist that has ever been diagnosed with this god-awful disease. But they knew more than anybody in my entire world at that point. And you can tell by now I'm not shy, right? And so I talked to everybody. I tried to get as much information as I possibly could from every single source there was. I had a huge network within a day and a half of this diagnosis. And nobody knew anything, but they did. They knew which doctors had treated other cases. They knew that they had groomed over those couple case reports so they could read them back the back of their hands. The stay-at-home moms, right? And so don't underestimate people that just don't have letters behind their name, because when you are hyper-motivated, you will be a scientist or a doctor or whatever you need to be in order to kind of fill in the blanks. And so it went so far to save my sanity at this very rocky time of my life. And I decided with one of the members of that group, Lauren Ryan, to just cast a wide net. Let's just take this thing down as it's taken us down. We'll just do whatever we can. And this is sort of kind of a schematic of what that looked like early on. I was diagnosed, and then Lauren and I launched a nonprofit, because that's what you do, right? Nothing's happening. You launch your nonprofit, and you try to get a bunch of money to a bunch of people, and they're going to cure you. And she actually had this idea. So this is the stay-at-home mom. Her idea was, let's get some organization around this will raise $1,000, we'll give it to the American Cancer Society, and they'll cure the disease. And I was like, come, my friend, we're gonna need more than just a beer, so I can talk you through the way that science funding and discovery actually happens. And so I told her, I was like, we need to raise about $50,000, and that's gonna give us part-time of a research technician or postdoc or grad student in a lab not even related to angiosarcoma, and maybe, if we're lucky, we can get a figure focused on our cancer in a paper on something else. And I was just like, had to really like significantly level set what you can do in science and what it really takes to move the needle. And it was one of those things where nobody wanted to hear that. Everybody just wanted to feel good about what they were doing. But you have to, when you're facing your own mortality, you have to strip it down to legitimate impact and maybe crush a couple hearts on the way, but there's no time for anything else. And so she quickly aligned, and we launched a nonprofit. I wrote a postdoc grant because I was just about to graduate. My grad lab was kind enough to let me stay for as long as I was going to live. And so I wrote a postdoc grant on angiosarcoma. It was abject failure, and I got things like too rare, not enough, you can't follow it up with anything sustainable. And ended up defending my thesis. My background is in immunology and biochemistry. And I defended my thesis for the sole reason that for the nonprofit, people would be more responsive to me if I had PhD following my name, which is stupid, but it worked. And so I defended. It was terrifying. I had to go off of my really good grad student insurance and then onto really crappy postdoc insurance, which had all kinds of implications. I went without scans because I couldn't afford the copay. That's a whole other talk. Anyway, I ended up living long. I'm still here. It's been 14 years now. Did a postdoc. I did my postdoc in cancer immunology, and I did that for reasons that are also too complicated to go into here, but they date back to the late 1800s, and if anybody is interested in the history of cancer immunology, come see me after. It's actually a cool story. And that went really well. It went really well. I ended up writing for and receiving a K99 award, which is kind of the holy grail of people that were looking to start their own labs at that time. But I also had an opportunity at the Broad Institute, and that opportunity was to redefine the way we collect cancer data at scale from people. And it had to do with building kind of a web presence to capture information and to be able to leverage the will of the patient to generate genomics data at scale. And I thought, that's really cool. And if I could do that and help build new infrastructure that goes beyond the brick and mortar, there's a shot. If I can do it well and they like me, maybe they'll let me point it to angiosarcoma, where there's no other way you could collect data at scale. So I turned the K99 down, I went to the Broad, lo and behold, and then that's what the story is going to be today. But lo and behold, I'll let the cat out of the bag. We had a massive project in angiosarcoma, and we changed clinical care. This is pretty cool. So then, and I'm going to top this off with what we want to do next. And by we, it's a whole other group of people and characters that have nothing to do with any of the things I'm going to talk about, except the very last slide. So I went to the Broad, and this was kind of the question that was mulling around the minds of Eric Lander and Todd Golub and Nick Wagley. They were thinking about these challenges of studying patient tumors. And for adults at least, not the same for kids, but in adults, about 85% of the population are treated in the community setting. And that was me. I started off at UMass Medical School. They have part of my tumor in paraffin sitting on a shelf. UMass is not going to make discoveries with that tissue. That's not going to happen. I went to the Dana-Farber, and even at the Dana-Farber, it's so rare, they're not going to do anything with it either. But it's at least in the hands of people who might do something if properly incentivized. So the vast majority, so the only tissue that's really available for research is tissue that was collected on clinical trials, but only about 5% of people actually enroll on clinical trials. It's shockingly low. And so there's really a dearth of information about each of the cancers, even though research has been going on for quite a while. But there have been changes in technology, social media came up into the world, and it provides the opportunity to reach out beyond individual institutions and meet people where they are. And that was sort of the premise behind this idea, which is the generation of a novel discovery platform at scale. And here's the big idea. This is the big idea. It's, what if we could generate a massive publicly available database of clinical, molecular, and patient-reported data to enable cancer researchers to find patterns in the data and help accelerate the development of new treatment strategies? They brought me on to build it. And so with the leadership of the Broad, we built our first instance, which is the Metastatic Breast Cancer Project. And this was an opportunity to partner directly with cancer patients and build something that would be reflective of their community. We asked about a dozen or so metastatic breast cancer patients in Twitter and at the Dana-Farber to help us build it. And there's probably one color when you think of breast cancer that's not here, and it's not here on purpose. And it's not here because breast cancer patients told us they don't identify with early stage breast cancer. They're going to die from their disease, and they're going to die a horrible death, and it's not a pretty pink party. And there was entire campaigns that were launched by metastatic breast cancer patients railing against the image that pops into everybody's mind of a woman with breast cancer. And some of them were because they were men with breast cancer, and that was like a whole other thing. And so we talked deeply with these patients, and they helped us come up with the design. Every word you see on the website, they went over the consent. We talked to marginalized populations who have never been engaged in this front to make sure this was going to be representative within all communities of people that get this disease. And one of the resounding themes that we heard over and over and over was, do not tell me you're going to cure my cancer. Just level set. No more cure cancer by 2024. None of that. They just want to feel like they're going to leave a legacy and that somebody someday may cure it, but that's not going to be within their lifetime. And so this is the result of that. We launched this in 2015, and we didn't know when we built this website and socialized it for like the 12 people or so we worked with, if 12 people were going to sign up or maybe 100, but we sort of had back of the envelope hope that maybe over the course of a couple of years, 500 people would sign up for this project. And if we could do that, we could transform the amount of information on this disease. So we launched, and as of today, these are a little bit dated. As of today, there's over 8,000 women and men who've joined the Metastatic Breast Cancer Project. And they've joined from all over the place, United States and Canada. This is a perfect overlay of the population density. There's not more people getting cancer on the East Coast, there's just more people on the East Coast. And so we have been able to generate a ton of data as a result of patients signing up for this. And it looks something like this. We have, a patient will provide online consent to enable us to get their medical records. We ship them a saliva kit. We ask for them to get a courtesy blood draw, and then we have their consent to contact the places where they've had tumors removed from their bodies to get FFPE blocks so that we can perform genomic sequencing, and we do whole exome sequencing, tumor normal matched from the FFPE, and we also do whole exome sequencing of the plasma and also RNA-seq from that FFPE. And this is just kind of a look of how this plays out in social media. These patients are all dying of a disease, and they're sitting there with their kits smiling from like these soulful smiles, like they're so proud to be able to take something that is just destroying them and do something about it. And I think that's what, a theme that that's underlying everybody with any disease really is you feel so helpless. And this is an opportunity to take some agency back and literally leave your mark with your own DNA so that other people might not suffer as much as you are. So it was an organic movement where patients would kind of take selfies and then they'd post in their social media, and that's how you gain trust, right? And so you would see these if you go back and you look at the consent bumps, there are these kind of like stochastic jumps, and each one of those can be traced back to like a key opinion leader in the patient world that had made one post, and it might drive the enrollment of like 400 patients in like 10 minutes. It's really insane how it works. And so as a result of this decentralized approach, we had patients that were participating from over 1,700 institutions. The little blue dots are places in the middle of nowhere, little community settings with one patient representing that had joined from that from that community center where there's no research at all going on, but yet those tumors are still just sitting on shelves, and they could go to our collective understanding of this disease. If any of you have ever worked in a situation where you've had to execute an MTA to move tissue from one place to another, you know that it's completely impossible to think of what it would take to leverage 1,700 MTAs to get a research project off the ground. But if you work with the will of the patient and you have one IRB and one consent, you can actually do this and overcome all of that bureaucratic red tape in order to move things forward at a very quick pace. So we built an open clinico-genomic database. We have all of the data on CBio portal, and you can download it, and it's very rich, deep, clinically annotated data from the Metastatic Breast Cancer Project. It's also on the Genomic Data Commons and also dbGaP, and we would love nothing more than for people to make use of this data. I'm going to show you a little bit about what this looks like from the perspective of a patient. Whenever we would present any of our work at any conference, we'd always put a call out to everybody participating to let them know we would be at ASCO or AACR or wherever. And if they happened to be there and they wanted to co-present any poster, they were welcome to do it. And they came every time. So we never gave a presentation at, unless it was like a platform, we never gave a poster presentation without patient representation at the posters. And this is Kelly Shanahan. Kelly is, she's still alive, has metastatic breast cancer. She was an MD treating gynecological doctor who had to quit her practice because of neuropathy from the chemotherapy she got from her treatment. Just see if this will work.
So this is the Metastatic Breast Cancer Project, and this is one of the things that I am most excited about in my life. The Metastatic Breast Cancer Project was one of the first things that talked to us, the patient, and asked us what we wanted and how we could help. And you know what? We signed up in droves. I am this little dot here on the California-Nevada border.
So just to kind of showcase what the patients feel when you talk to them, because if you think about it, when we build studies, patients aren't really part of the build. They're not part of the design. They're the number one stakeholders here, and they're sometimes at the very end included for oversight, but they're not really part of the team building these projects. But that's a missed opportunity that I think we can rectify. So suffice it to say, there's a ton of data. This is a position paper in medRx if you want to take a look at what this looks like and what you may be able to do with it if you are so interested. Check it out. And then the question was, can we do this in other cancers? And I let the cat out of the bag at the beginning, so you all know we did. We did this in angiosarcoma. So we'd already built everything for metastatic breast cancer, and I brought it to that same Facebook page that I had found so many years before, and I said, hey, like this post if you want to do something similar to what we did in metastatic breast cancer. And I had 99 people in like an hour like it. I didn't know if they were alive with the disease. I didn't know what the deal was, but there was like a big enthusiastic appetite for a project just like this. So we built it. And we built it with patients just like me who are facing a Kaplan-Meier curve that looks just like this. And I'm making some assumptions that most people know what a Kaplan-Meier is, but in case you don't, the survivability is on the y-axis there, and everybody's alive at the very beginning, and every tick down is somebody dying over time on the x-axis. And this is one of the first graphs that I saw when I was diagnosed. And I looked at this, and looking down that steep curve gave me vertigo. I was like, there's no way I'm gonna live like more than a couple of months with this disease, 0 chance, And so I'm way out on that tail right now, which is crazy, and I'm extremely grateful for it. Most people, however, do not have that luck. And so pointing this opportunity to this patient cohort that's so rare and dies so quickly, this is really the only way you could do something at scale. And so we built it, and we just had them change a little bit. They didn't really want anything other than urgency. They wanted it launched as quickly as possible. And so we did, and over 750 people are part of this project. And that's a lot of angiosarcoma patients, right? 300 people a year get the disease. And we launched it in 2017, and almost 800 people joining it. It's the lion's share of people who probably get this disease live long enough to actually take action and join. So we immediately started sequencing these patients, and we had a data release out for 83 samples from 62 patients. So we'll have sometimes a blood and an FFPE, or sometimes we'll have serial bloods or serial FFPEs from different patients. And you can see just how rich this data is. If you go on to see BioPortal and you click Add Chart, there's like 82 more clinical elements that are charted out here, because we just did like a full abstraction of the medical record to be able to have this this out in the world. There was one graph in particular that was so striking when we pulled this up on BioPortal that I showed my kids, who were like 8 and 6 at the time. I said, "Hey girls, what do you see when you look at this?" And they were like, "We see two things, Mommy." And I was like, "That's exactly right. There are two distinct populations of people here." This is a graph showing tumor mutational burden. This is a proxy for people's sensitivity to cancer immunology, cancer checkpoint inhibitors. And so for those of you who may be in the field of oncology, you're probably well aware of this. It's not the best biomarker, but it is one nonetheless. And there are a couple people here who have really high tumor mutational burden. And when we looked at who they were, it turned out that all of them had angiosarcoma, except for one. All of them had angiosarcoma in the sun-exposed regions of their skin. And so this is, again, a blood vessel tumor. And all of, the vast majority of these people had it in sun-exposed areas. And so we made the natural hypothesis that it was sun damage. And if we looked at the DNA, that maybe it would look similar to what you see in melanoma. And sure enough, that is exactly what you see. There is a UV signature in this, and that led to high TMB. So then, because this coincided with when pembrolizumab, which was a blockbuster checkpoint inhibitor, hit the market, we wondered, did any doctors in those community settings ever put any of their angiosarcoma patients on pembrolizumab just off therapy? Because they will do, people will do that. And 6 patients in our cohort had that exact thing happen. And because we had their full medical records, we looked and we got a sense for who are these people and what was their response to the drug. 3 of them had internal angiosarcoma and low TMB. All 3 of them had no response to pembrolizumab. 3 of them had cutaneous with high TMB. 1 of them had an immediate adverse reaction because this drug puts your immune system into hyper overdrive, and they had to be taken off immediately after one dose. But 2 of them, who had metastatic angiosarcoma that probably has about a 2 to 3 month survivability, went on the pembrolizumab and became cured, and they're cured to this day. And this is just one of the clinical journeys of one of them. They were on a clinical trial, it failed them, had progression. Another clinical trial that failed them. They went on a pazopanib, which is a tyrosine kinase inhibitor, it failed them. Then they went on pembrolizumab, which is that long green line. And after a long time, almost a year, they had an adverse reaction and had to be taken off. And they were probably very terrified to go off of this drug that was saving their life. But they went off, and they didn't have any other therapy. They were just monitored, and it never came back. And I know this person, and they are still alive and enjoying their grandkids to this day. So they're cured, and same with the other person, similar story. And this nugget was in their medical record, written by their healthcare provider. It says, after the first cycle of pembrolizumab, this person had a dramatic reduction in the size of the mass in his neck and retrooral area. This is just amazing. And that last sentence, just let it linger for a second. How many people are being treated by who knows what in community settings, and their doctors are curing them? But we have not figured out a way to systematically collect that information and feed it back into like some type of learning ecosystem so we can take advantage of these cures that are happening. This is not just one isolated incident. If you think of all of the clinical trials that have ever failed, there's always a sliver on those drugs that do really well, and we don't capture them, and then those drugs go away, and there's never opportunity for follow-up. So I'm just going to plant that seed with all of you. So as a result of this, and because I like to talk, I shopped the data around to the whole sarcoma community of oncologists, all like 200 of them. And it's a tight community, so and I knew them all well, and so I told them, I was like, everybody, look at this. And so they immediately used the data before it was published to design these clinical trials. And they did cooperative group clinical trials and launched them before we had anything published. And lo and behold, we published our work as these clinical trials were going on. I'm a structural biologist, and so I did, the fun modeling of the mutations, which was a good old time. And we were able to really define the genomics of this disease and define angiosarcoma as a collection of several different diseases that all happen to take place in endothelial cells. We got the cover of Nature Medicine, which is great, but what's even better is that it was published within months of the results of the first clinical trial that was using the data. And that clinical trial validated these findings and changed clinical care for these patients. So back to Count Me In. As a result of the success of the Metastatic Breast Cancer Project and the Angiosarcoma Project, we were able to open the platform up to all people with all cancers. And that was great. And then even better was that Reese Witherspoon kind of announced this on Stand Up to Cancer. And as these words were kind of leaving her lips, and we had a PSA with Uza Aduba, I was starting to think of like what my day job really had become. It's the condensation of everything into a paper and clinical trials was amazing. But at this point in my career, we had grown so big that I was largely managing humans. And that's just not really what I was, I didn't think that was the best kind of way to stay. I felt like this was kind of like the exclamation point for me on my time at the Broad, and I was like, I've got to do something else. I've got to try to have impact somewhere else. And I didn't quite know what I wanted to do. And so the only things I did know was that I wanted to have impact, and I wanted to gain industry experience, and I wanted to continue to champion rare cancers. And so this was back in 2021, right at the height of the biotech industry, where everything was just beautiful and golden. And I was like, that's what I want to do. It looks just so easy. You just have an idea, and then people throw money at you, right? And so I popped out into a liquid biopsy startup called Precede Biosciences just down the street. And I jumped over as the world melted around the biotech industry. And it was intentional though, because my friends at the Broad said, go do it, and you can come back if it fails. Like once a Brody, always a Brody. So the risk was not as great as it may seem. But it was an amazing opportunity. The team was second to none. We were spinning out a technology from Harvard, and I'm going to kind of go over it. And I put a little thing in Slack because we are hiring a bioinformatician, just putting that out there. But it's a lot of fun. It's enabling me to still have tether on the rapid acceleration of discoveries across cancer. It's a step forward in delivering on the promise of precision medicine. We get to generate multimodal data at scale, which is like my favorite thing to do. And it enables me to kind of extend the impact that I can have with this wide cast of characters in the space of oncology that I came to know when I was at the Broad Institute. And so this is just a quick walk through the platform. We profile circulating chromatin from the plasma. We need only 1 mil, which is very enticing for our collaborators. And this enables us, and so we look at the post-translational modification on histone tails, which are really stable. And so when cells spill their cellular content into the peripheral blood, the DNA that's not protected by nucleosomes gets chewed up, and we can pull out the histone tails by their acetyl or methylation marks that are going to enrich for activated promoters or enhancers, and then just do next-gen sequencing on the associated DNA, and in that way kind of infer what the transcriptome looks like, but from a very stable analyte. And we also sequence the entire methylome. So it's super powerful, and it's been an amazing experience developing this. We were stealth for a long time, came out at ESMO last year with a platform presentation and a Nature Medicine publication at the same time. So anybody who wants to talk about this after, come see me. But as I'm doing this, in the background of my life, I have the opportunity to work with a group of key opinion leaders to really think about what might be next for rare cancers at scale. And so there's this initiative that we are all putting together, just a bunch of us who care an awful lot about rare cancers, with Gary Schwartz, who leads the Case Comprehensive Cancer Center, who wants to kind of systematically have an approach to rare cancer research at scale. And he's pulled a bunch of people together and said, let's figure this out. And so we have a lot of really interesting people. We have identified a lot of barriers that I'm going to go over in my next slide. We have formed the infrastructure to figure this out, sort of. We have a lot of ideas, and we have zero money. And so, so it's still in the idea phase, but we are thinking of like, what is the model? Is it going to be a nonprofit? Is it going to be a for-profit? We're still kind of noodling on that. But I just want this crew to know that it's going down. And you know, one of the things that we're trying to do is come up with ways that we can break down those bad barriers that are faced by rare cancer patients. And I want to put a plug that it takes innovation. It's not, and it's going to take more than just kind of what I'm putting on the slide. It's going to take a lot of creative thinking by a lot of people. And I just want to kind of showcase what it's like for a cancer patient and what we have to face in order to get to the next level. We have delayed diagnosis. So I was on the shorter side with only 3.5 months from noticing a lump in my breast to an actual diagnosis. And there are people that go years without an actual formal diagnosis. There is a lack of standard of care. My doctor, when I was diagnosed, my Harvard doctor took a piece of paper and a pencil and wrote a bunch of chemos that are used for other cancers and like 6 different things, different chemos and combinations with therapy. And he handed it to me and he said, if you want to look at your kid and say you tried, just pick one of these. That was his sage advice to me. So there is a lack of standard of care, and sometimes it's not delivered the best with great bedside manner, but that's like a whole other thing. There are limited treatment options, even if in cancers where there are known targets, like there's not really access to the therapies. There is lack of patient navigation. If you are somebody in the middle of Iowa and you have angiosarcoma, you know, unless you find that Facebook group, you have no idea what to do. And your doctor has even less of an idea what to do. There's overcoming geographic dispersion. Like I said, I was the only person, and I was in Boston. You know, there's nobody else that I could even find or talk to about this awful disease. Lack of clinical experience even among the clinicians who are experts in the field. So in my crazy cancer, there are over 100 subtypes of sarcoma. And so to have somebody just for angiosarcoma, which is the tiniest slice of the tiniest pie, doesn't exist. So I knew more about the literature on day 1 with my doctor than my doctor had ever read. And then that's a whole other thing. And then there's a lack of research interest. You can't blame people. Like I tried to write a grant and was declined. You know, there's just no money for it. And so we have to overcome each one of these and more. And it seems daunting, but I promise you, if there's a will, there's a way. And I think we have instances of how we are at a moment of time where some of these have some meat on the bones that we could build from. So there's digital path AI, right? You could imagine a world where the pathologist scans slides and they go up into the cloud, and people like you tell what the actual diagnosis is, and then we can shrink that delay in diagnosis. There are tumor agnostic therapies. You just need the right biomarker. And so how many of these rare cancer patients could be benefiting from these really big blockbuster drugs that are doing really great in people with common cancer that are getting routinely tested? We need to generate omics at scale across the board. Rare cancer patients could be the tip of that spear. There are bespoke navigation apps that would work on your phone. If you have DIPG, you could actually download an app and know exactly where to go, who to speak to, what the Kaplan-Meier curve looks like, what clinical trials are there. We need to just invest in this and put this to scale. And then, you know, there are decentralized clinical trials. There are virtual tumor boards. And for scientists, we're easy. If you fund it, they will come. You know, we're not that hard. And so I just wanted to kind of plant all of these seeds here today, because this is what we're talking about in a place that doesn't yet exist. And we're building it. We're building it today. And so you're not probably going to hear about it for a little while. But if you're interested in kind of coming along for the ride and you just want to see what's up, just connect with me. So I want to bring it back to the patients for Count Me In, because this slide is always such a great reminder of why we're all doing what we're doing. These are all patients with their kits, either their blood kits or their saliva kits after participating in the project, and taking selfies and putting it in social media. And I'll just read one of these quotes. "I want to live and watch my children grow up, but if I can't, then I want to leave a legacy and a cure." And with that, I would like to thank all of the teams of people that I'm working with, the Broad, near and dear to my heart always, Precede Biosciences, the job I put in Slack, and this new group of people that I'm working with to try to build the new version of Rare Cancer 2.0. And with that, I am done.
Thank you so much for sharing your experience with us and this very heartfelt talk. The quote with the kids got me a little bit, I have to admit. All right, I'm looking up the questions now. If somebody wants to shout out a question, feel free to, because I was a little too engrossed in the talk and not monitoring the Slack for questions. Getting there. Okay. Yes. Florian asks, how do you envision global strategies for rare cancers to drive scientific discovery and improvements in patient care and treatment? And are you optimistic about this, or is bureaucratic red tape going to get in the way?
That is an excellent question, and I think the only way to do this is through patient engagement and technology, some type of web-based approach to enable them to that would enable them to have the ability to donate their information and their tissue. I do think that there's going to be a lot of red tape that you have to overcome. For example, patients in Europe that there are so many patients in Europe that would love to participate, but GDPR prohibits their information, their personal health information, from kind of going across borders. And so I think whoever wants to take this on a global scale needs to be really creative about how you overcome those types of barriers for internationalization. It's not easy at all, but I can say from personal experience that patients with rare diseases and rare cancers desperately want to participate from all over the world. And nothing hurts more than to say, I'm so sorry, this is restricted to like the United States and Canada, when there's such little data and such willing participants outside of the country. So.
Yeah, to add to that, I advise a rare disease foundation in my home country of Belgium. It's a small country. I mean, of course, it's part of Europe, but they're trying to, and it's a mom and dad who started a foundation to centered around the disease that their son suffers from, and they run into exactly that problem because they've seen all the work that's been done at the Broad and elsewhere with like these massive projects, and it's like, we want to do that too. We want to get all the data together, because if you look at just the data that's available in Europe for that specific disease, that's even smaller. It's just too small to be actionable. And so unfortunately the legal barriers are some of the worst. Mm-hmm. And it's especially infuriating when you see that the patients themselves are just like, no, please take my data, put it on the internet if you need to. Mm-hmm. Like, I don't care, I want to live. So that's really something that's, do you follow the work of GA4GH on that front in terms of the kind of the more legal standards?
I'm not really, but yeah. But I definitely agree that this is a huge and significant unmet need. Mm-hmm. across really all disease, but rare disease and rare cancer, where you only get a handful of people. Yeah.
Well, what do you see as being the role that interested bioinformaticians can play? I guess since there's a lot of bioinformaticians in this room, like what can we do? Is there anything specific that we could do to contribute to the efforts in terms of infrastructure, pipelines?
Yeah, so much, but we're so new. I don't have anything yet, but I would love to stay in touch with anybody interested, and then we can kind of lay the foundation together. Because I don't know that I understand the capabilities that you could bring to the table. And so, you know what I mean? It'd be good just to kind of brainstorm with anybody who's interested and have some of those conversations. Right off the bat, like, I guess some of my harebrained ideas are there opportunities to take all of the publicly available data and mine that for biomarkers for like some of these tumor agnostic drugs to get a sense like how many in which types of rare cancers that we have data on already can we tell there would be patients in those populations that could benefit from like the vemurafenibs and the Enhertus of the world. And so that stuff like of that nature to really kind of dig into the data that it does exist in order to kind of extrapolate where we could go as one area. And then again, building apps for patient navigation. I was having a conversation with this woman, Lisa Ward, who lost her son to DIPG, which is why I mentioned it. And she has such a megaphone that she found herself at the White House as part of the contingency on brain cancer, really leading the effort as a mom, right? As a mom who lost her son, to just make sure there is something for families when they're facing that's the worst of them all. When they're facing this terrible childhood cancer, that they don't know what to do. And so she's built an app, and anybody who has DIPG, it's so rare that if they get it, they find her and they can download this, and it will guide them through every single step that they need in order to make good choices for them and their family, data-driven decisions, rather than just trying to like reinvent the wheel every single time they go through diagnosis.
And that's the thing, and part of it feels like breaking down the silos of information.
Yes.
Because there's already so much information out there that is just sitting unused.
Yeah.
And yeah.
It's unused, it's not harmonized. There's like all kinds of things that could be built, pipelines that could be built to bring it together. One of my dreams, and I'll put this out there, is to stop having, to rebrand rare cancer into individual little cancers, but rather find some kind of systematic approach to make all of them one type of cancer, one cancer that could be approached. And if you did that, it's all cancers, about 25% of them are rare cancers. Then you've got some bargaining chips. Then you've got, the ability to get biopharma to maybe invest, or venture to invest, or researchers to come and do, platform approaches to rare cancers at large, and so it's just something to plant a seed here. Like, what are the kind of approaches that we could take to leverage kind of cross-cancer approaches?
Well, thank you so much. I think we are going to break, and now we're going to have a reception. I think it would be wonderful if anybody who's interested in talking more about the possibilities, how we can get together and do something to help. And so let's continue the conversation over drinks. Thank you, everybody, for your attention. Thank you so much, Corrie, for the keynotes.
Thank you.
And thank you, everybody who spoke today. Made this day wonderful. Thank you.